Thank you. Thank you all for joining me. We're going to make this really intimate and can have probably a little bit more conversation around this topic. But let me tell you a little bit about myself so you can kind of see how I got into radiology as a nurse practitioner. Um, as I was telling you, Caleb, I was an ICU nurse, started at Emory for 9 years or so, went back to school, got my nurse practitioner degree. I left Emory for 10 years and did primary care as an NP. And then really didn't like the culture of those organizations that I worked for, practiced for. So I came back to Emory in urology, stayed in urology for 3 years, and then ran into an old colleague from ICU. It's like, oh, have you ever thought about working in radiology? I'm like, no, what would an MP do in radiology? But at that time, they were recruiting an NP basically for the claustrophobic patients in MRI. So they basically wanted an NP to basically, do the pre-sedation assessment. They felt having a clinical person in that role would help with the overall patient care. So basically, I did that for a few years, and we actually built a new service line in MRI where we did prostate ablations under MRI guidance. And so from there, went to, because that position left, so I went to interventional radiology and practiced as an NP, doing mainly consults, inpatient consults, and also outpatient clinic. So I got into leadership as I became chief APP. So at that time we had about 10 APPs. I was chief APP probably for about, I don't know, 5 or 6 years. We actually doubled that team from 10 to 20. And then from there, I became director of patient care service, which is overall our ambulatory outpatient clinics for interventional radiology. So I've had a lot of different roles. I think this position I'm currently in was sort of perfect for me because I have a broad overview of outpatient care, inpatient care. I have a broad overview of, working with MRI techs, which I was absolutely amazed. I still call MRI magic, and just the technical side of that. I don't know how they do what they do. But being on the inpatient, outpatient, being in radiology, urology, primary care, I have a really good insight on what patient care should look like. So I have no financial disclosures, but today I want to talk to you all about how you build high-performing clinical teams and how you can retain those clinical teams. I won't read all of the objectives, but one of the things that we're going to do is talk about sort of this 5 R's of hiring, because this really happens way before you hire anybody. It's just your thought process of being really intentional on how you recruit employees, because it really starts there. One of the things that we're all familiar with is burned out leaders, burned out employees. So I know who is a leader and who is frontline staff. Director, I know you're frontline. What's your position? Okay. Jamie? I know Jamie. Jamie is my colleague at Emory. But we're very familiar with that burned out employee or leader. I mean, it shows, you had an employee that was really engaged, and then all of a sudden they're no longer engaged. They're maybe coming in late for work. They no longer smile as much as they used to. And you can see the same thing with leaders as well. They just kind of carry it. So I think one of the reasons I'm interested in this subject is because I think it's something we really need to focus more on. I know there's been a lot of focus since the pandemic around the mental health impact of the pandemic, but even prior to the pandemic, we had a lot of burned out healthcare employees. The pandemic just exacerbated it all. And there's a lot of research around how the pandemic affected employees' mental health. But one thing that, this is a study from the CDC, but one of the things that they pointed out, that if healthcare workers experience a decrease in odds of burnout, if they trusted management, if they feel like they had enough help, staff were able to complete their work, that actually they had a decreased chance of having burnout. So this was some recommendations from the actual study, that what can employers do to help, but it's really not just employers, because our actual staff are working within our department. So I think as leaders and also as co-workers, we have we can have a great impact on whether you have a culture of burnout or not. But some of the things that they suggested was making sure we have a model and support for taking time off, including workers in decision making, valuing work safety and health, ensuring that you have adequate staffing, training our supervisors and leaders to provide support, and really begin to talk about well-being of staff. So this is just another, this was actually the American University of Radiologists. I think they're AAR now. But anyway, they had a roundtable, and one of the things I'll point out here was that their primary thing that they strategized on was on resilience and well-being, because they realized that addressing burnout through adequate staffing, workforce support, and strong team culture really helps to retain. So I thought that was kind of interesting that, you know, a physician team actually was looking at that, because this was also post-COVID, and they were looking at things to how they had to adapt, you know, by working from home and things like that. But one of the big reasons this is important, because replacing healthcare employees is expensive. I know you all have probably seen the statistics and on just turnover cost. And hospital turnover reached 26% in 2021, driven by burnout, retirement, better pay, work-life balance elsewhere. So you all know during the pandemic, especially in my world of nursing, wherever the money was being paid, and that affected technologists too, where they were doing a lot of contract work. We know pre-COVID, 50% of physicians and nurses reported burnout symptoms, and during the pandemic, 93% of health workers reported increase in stress. So you can see on your right-hand side, to replace a radiologist for instance, it's going to be $250,000 to $500,000, including lost productivity, because it takes so long to actually recruit and onboard a provider with trying to get their license and all of that. And you can see the difference with an APP, an RN, a technologist, medical assistant. So it behooves us to really, I want to go to this slide first, to kind of really try to work on strategies to keep our employees. So why do our healthcare professionals leave? Burnout. They're just exhausted, not having enough staff, not really feeling like they have support from the leader or the organization. We talked about compensation and just the competitive environment from other healthcare institutions, not having work-life balance. And we're going to talk a lot about work-life balance and why that's important. You know, physicians feel like, and providers, that they're weighed down with all of these administrative tasks, this distress, workplace violence, not having enough autonomy, and really organizational change fatigue. I don't know about y'all, but we have undergone so much change. I mean, even prior to the pandemic, we were undergoing a lot of change, then having to pivot so fast during the pandemic and coming out of the pandemic. It's just been over something almost every quarter. There was something different that we've got to adapt to. In our organization, we have undergone, like I said, complete, I guess, change of organization structure on the top. So it's been challenging. But at the end of the day, what we're trying to create is happy employees. And I want to give you just some insight on how I feel like within my arena, starting with the APP team and now where I am now, how you can actually establish high-performing clinical care teams. My cohort, who's now APP chief, who's supposed to be here with me, her and I worked together when I was chief APP and really focused on how we can improve retention at that time among our APPs. But this is not just, this can be the things I'm about to share. It doesn't matter what team it is, whether it's technologists, nurses, transporters, the concepts are pretty much the same, because if you have a high performing team, your team is going to be more effective and you're going to have overall positive results in every arena. So what is a high performing team? What are the characteristics of a high performing team? Well, first of all, it is up to the organization, and also break it down to whatever your area, the leaders in that area, that your employees know what the mission is. Like, what are the goals and what are we working on and where are we trying to get to? It's also important that they know exactly what their role and responsibilities are. They communicate clearly, they manage their work well, they thrive on two-way feedback, and we're going to talk about really the millennial generation that really thrives on two-way feedback. Managers and employees are aligned and connected, and they trust and respect each other, which is really big. They embrace innovation, change, and adaptability. They collaborate with other teams well, and they cheer each other on. Like, there's not really any competition. They really focus on the recognition. So you may say, well, okay, so what? Why is this important? Well, the impact of high performing teams in healthcare, again, a lot of research on this to show that, first of all, your employees are going to be more productive, and they tend to outperform their industry peers by 25 to 30%. Again, employee retention and engagement. So high performing teams are linked up to 25% reduced employee turnover. We already talked about the cost of that. And then they don't call in as much. Patient care and safety, well documented that if you have high staff engagement, your patients are going to be safer. So for healthcare organizations in the top 20% for staff engagement, which we, at Emory do our sense of belonging scores, our pulse surveys, is why we gauge this, because if you have high staff engagement, that's a direct correlation to your likelihood to recommend your top box score. And also, if team structure and patient outcomes, teams with well-defined objectives, role clarity, shared leadership, interdependence, and time for reflection, again, can lower patient mortality by 15%. So when we revamped the APP onboarding process, Stephanie and I actually kind of looked like, how do we revamp this? Because I'm sure y'all have been in situations where I come from, at least on the clinical side, a lot of times a physician may say, we need an MP for this or a PA for this. Okay, well, where are they going to work? What are they going to do? There's like a lot of questions you have to ask, because I remember when I actually first came to radiology, they knew what they wanted, but they didn't know exactly what they wanted to do. I had to develop my own role when I was doing the MRI sedation, because it was a new role. So there was no blueprint for it. And really, I didn't have the support for anyone to show me. It was just very vague. So one of the 5 R's is review. The second one is role development. The third one, recruitment. The next one, reduce burnout. And the next one is retention. And honestly, I can spend like 30 minutes on each of these, but I'm not. But first, I think as leaders, kind of doing this continuous assessment of, okay, we have a need. what are the gaps in care we're trying to fill? And if you have someone to leave, say, I don't know, a technologist to leave, and you're not extremely short staffed, which I know is rare right now, could you use that FTE for something else, like a TA? Because I know we're doing that in breast imaging now to help to improve our patient experience. So, because maybe the TA can help prep the patient, because right now a lot of our technologists do everything. They bring the patient from the front, they put in the IV, they, take them to the dressing room, all of that. So if you can provide the TA, the technologist support, maybe that's what's needed. And one of the things I always encourage is asking the employees that are working, what do you feel like you need right now? Do we just need another technologist? And you may very well, because we know we're short staffed. But what are also any other patient care priorities? So just doing a general assessment of where you are. Is there a new role we can develop with an APP, or I mean, not with an APP, with the FTE? So role development, the example I gave you when we said, oh, we need an APP here. One of the things that we did, we kind of forced our physicians to sit down with us and say, okay, I need you to outline, it's actually a form we created to say, okay, what do you feel like the need is? Okay, we want the APP to do inpatient consults. Okay, what location? What are the hours? Who's going to be their supervising physician? What are the volumes? So looking at basically everything within that role, because when you go to recruit, when you sit down with those candidates, you know exactly what to tell them, because transparency is really, really important. Things like, is it going to be a patient-facing role, or is it some that's going to be a non-patient-facing role, or is it going to be a leadership role? So all of those things are important. We have developed a lot of roles within, I think within the APP space to support our physicians and patients. We've developed a lot of roles within nursing, and we are beginning to develop roles on the technologist side. One of the things we're doing now is in interventional radiology, we have sort of this gap post-procedure. So patients get the procedure, but then they don't get the information they need post. So we're going to actually put nurse navigators on their outpatient, but on the inpatient side. And on the procedure side, they're actually creating what's called a flow coordinator role, which will be a technologist and a nurse that's going to interact. The two of them will interact daily on making sure patients actually come back to the outpatient arena. So there's just a lot of things to kind of fill the gaps that you may have that you can do to develop roles. Recruitment is big. Recruiting the right people for the role. So you've done your assessment, you've said we need X, and so that role may not be for every personality. And like I said, you can use this no matter if you're hiring a leader, I don't care. It is what is the role you're expecting this person to do, and being very transparent around those role expectations. So for me, have any of you hired people that you kind of knew wasn't going to be a good fit, but you hired them anyway? What happened? Do you have an example, Jamie, or what's your name? Kristen? Yeah. Yeah. But did you, when you were interviewing them, at that time, did you have a sense that it's kind of doubtful? Yeah. 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 We usually do panel interviews because and it's funny, we usually come out all thinking the same thing, but there is something, yeah, I call it the spidey sense, that something's just not quite right. And I would encourage you to follow that, because if you feel it during the interview, it's real. You may not can put your hand on it, but just keep interviewing. Is what I would encourage you to do. I have the example of recently, we have a RN navigator position open. For that position, it is 2 years of RN experience. So I let my managers choose the candidates. I don't get that deep in the woods, but I did interview this candidate. So she was late career, a nurse practitioner. She had got her nurse practitioner degree. She was a doctoral candidate. Her current position was a clinical, she was a nurse, she was in nursing leadership. So my first question to her, what are you doing? It's like, why are you interviewing for an entry-level RN position? And her answer was, well, I want more work-life balance. All of our positions are hybrid. So it's either 3 on-site, 2 off-site. And I think a lot of people get the impression that these jobs in IR are easy, and they're not. But it's like, okay. I said, but I'm an MP, and I think you could actually get more work-life balance being an MP, because you can go work part-time, per diem, you know, contract, anywhere, 2 days a week, and get paid probably, you know, the same as a full-time position. But anyway, either say she was not the right person for this entry level. I'm like, why aren't you seeking something out in leadership? We need more leaders. So I don't really know what her angle was, but we did not hire her, of course. But it's things like that. Anytime, especially if I see an MP applying for an entry-level nurse position, that's a red flag to me. It's like, you went to school, you're a doctoral candidate, and you want to. So it's either she wanted a stepping stone job, so she was going to leave. I knew it wouldn't be long. So no, not the right person for the role. So you have to really look at the work in itself, the candidate, where they are in their career. And I always say, I try to be really intentional on hiring. I like hiring people with various cultures and backgrounds, because we know that that improves your team dynamics to have different perspectives. We try to do the same thing as far as being equitable. I mean, we have, of course, our HR department is really strict on how we do things, but you want to do the same thing for every candidate. Everyone has to interview. We go through the same processes. I hire a lot on personality, because most of the time, all of your candidates are probably qualified. So if this is a patient-facing position, but your affect is flat on the interview, you never smile. When you think about the patient experience that Jamie and I did this morning, I want bubbly. Not saying you've got to be bubbly, but I don't want flat. And we talk a lot about in the interview, we do a lot of process questions in interview, because I really want to know, to get an idea of what the emotional IQ of a person is, and whether they know how to deal with stress, how do they work with the team, how do they communicate. So a lot of our interview questions are around that. So again, recruit the right people for the right role. And this is big. Onboarding is everything. Even if you happen to recruit the wrong person, it's either all in or they're going to be gone. There are no half measures. If you don't onboard, I don't care what position you hire someone for, whether it's a professional position, whether, like I said, transporter, MA, it doesn't matter. Onboarding is everything. And one of the things that we struggle with in our department is physician onboarding. It's terrible. And, you know, it can be improved, but you would think physicians, they would have everything really lined up, and it's not. They show up on the first day, we don't even know that they're there. Like, oh, you're here. But we basically mapped out some general principles around onboarding. So onboarding starts after you hire that employee and it goes through HR and, the comp and all of that is set, the employee accepts the position, that's when onboarding starts. And it starts, so they may have a start date, 30 days from now. But if you haven't talked to that person from the time that HR completed their part, and then you don't talk to them until a week before, that's not good. You should be having regular communication with that employee before they ever step into your facility. And for our facilities are complicated. So just even given them, we usually do a pre-onboarding meeting. Hey, you're going to start on this day. This is going to be your preceptor and mentor. This is where you come. Make sure they have their badge. Won't talk about epic training tracks. So that's been a mess, but making sure they have everything that they need. So when they step front in the door on the first day, they're ready. But we have a detailed checklist that we make sure that they have everything that they need. We do resource manuals, both electronic and paper. We make sure, like we said, the preceptors and mentors, buddies are aware of this person. In radiology, depending on the title, it can take someone 8 to 12 months to really become efficient, especially in IR. So we tell, especially, for instance, nurses that we hire usually come with experience. It can be discouraging to go back to a novice level because it takes a while to kind of catch on. So just preparing them, hey, just know it's going to take you a few months to get grounded, and that's okay. We want to make sure that what we're expecting from a productivity level is basically transparent and talked about, whether it's our nurses are on productivity, our PCCs are on schedulers on productivity, our APPs are on productivity, our technologists, at least the operating unit is on productivity. And we try to do team outings, at least 3 times a year, and that just helps overall build good team relationships. But feedback is really important during this process. We usually do weekly check-ins with the mentor to review progress and update goals. We are not necessarily set on a onboarding time. We know that for most it's about 60 days, but there are some people that can onboard quicker depending on what the role is. But we do shadowing. We actually go to the new employee and ask them for feedback. And basically we take that information and we adjust goals and the timeline depending on, what the feedback that's shared. We're not going to talk a lot about burnout, but these are some things. Number 4, we have to look at reducing burnout. And I think kind of knowing what staffing model you want and the care model you want. We usually do team-based team-based care models, especially where we have, physician, APPs, and RN, MA technologists, where everyone kind of shares responsibility. We're very collaborative at Emory, and like I said, we really looked into, especially for our MPs and PA, a hybrid roles several years ago that we implemented. So they're all 410s. For our nursing teams, they are either hybrid or 100% remote, depending on the position. But my point is, I think we have to begin to look at different alternatives in shifting in the shifts that people work. And we'll talk about the millennial generation that is no longer accepting traditional shifts because they really want that work-life balance. But just looking at just overall what your culture is like. As a leader, those are things that we can control. Like, do you have a fair and just culture? And within all of that, accountability. It turns employees off when another employee gets away with something all the time. They're constantly late, they're never reprimanded. And so you have to make sure that you're being fair as well. The millennial generation is interesting to me. I have two daughters that are in this age range. I think millennials like 25, 45. And this is something we have to pay attention to because they make up 40 to 50% of all allied health professionals. And then in 10 years, Gen Zs will take over the millennial. And they are different. Their whole outlook is different. I'm what generation baby boomer? I'm right at Generation X and baby boomer. But for us, it was go to school, get a job, you stay at an organization as long as you possibly can, which I pretty much did. I left, but I came back. But for millennials, they have no, it's transactional. I want the best schedule. I want my time off. I don't want to work every day. I don't want to do 312s. I may want to do 3/8s. And if their onboarding is screwed up, they're going to leave and go to the next place. And I think because it's healthcare, they have that privilege. If it was another type of job, yeah, they may stay longer. I'm not even going to tell you how many RN jobs my youngest daughter has had. I'm embarrassed. I tell her, like, girl, because during COVID, she traveled a lot. But I'm going to tell y'all, she's had 20 different jobs, and she's been out of nursing school for 10 years. Yeah. It is all about highest pay, low stress, and they don't have any loyalty, you know. So she's got a job right now. She went to school to get a master's, and now she is working at she's a clinical instructor, educator, and she enjoys that. I hope she's I'm like, girl, find your niche here. But anyway, I think it's really important that we have got to start thinking out of the box on how we're going to retain employees. And when I start managing nurses, another nurse leader told me, girl, you'll be good if you keep a nurse for 2 years. That was kind of hard for me to swallow, but it's true. Retention. So if we kind of concentrate on the first four, you're really going to have retention if you can do some of the little things, but employee engagement is the key to keep top talent thriving. And how do we engage our employees at Emory? This is big at Emory. We are being held accountable for a sense of belonging on our pulse surveys as leaders. But one of the things they want us to do, not only round with our patients, they want us to round with our employees, to have impromptu, rounding sessions on, how are you doing? Anything I can help you with? Anything you would like to change? I do one-on-one meetings with my managers once a month. We'll do one-on-one, and it's their meeting. I don't have an agenda. You bring the agenda items to me, like what's bothering you? What do you want to talk about? And with employees, we can do stay interviews. So if you see an employee is showing signs of burnout, talk to them. I mean, I think a lot of things we just don't communicate. So talk to them. What's going on? Is there anything we can do to help? It could be my assignment is horrible. Okay, well, let's look at it. Let's look at, some of the metrics and see, is your assignment too much compared to someone else, and shift. This culture of belonging, we'll talk about some of the things, but doing team building, hearing the voice of the employee through pulse surveys, making sure that we are in tune to career advancement. We support our team members that are in school. We try to work out a schedule, that's fair if they're in school. So also just creating and encouraging work-life balance. And again, looking at alternative shifts. But y'all, culture is really, I think, the forefront of all of this, because you have employees that are toxic. and toxicity spreads. And I have learned that you have to nip that in the bud really fast. And because a positive culture is the foundation of success, culture determines how teams thrive, culture is the difference maker. But if you have a toxic culture, I will tell you, sometimes it's 1 or 2 employees that could be causing that. And you have to begin to address that sooner than later. Emory has spent, after I was telling Caleb, our new CEO they did a market adjustment analysis. Our most employees got increases in their salary so that we can be competitive. But the second thing they did, start focusing on culture. So late last year, they have this whole platform around culture that every leader, first we had to go to culture training classes that was 8 hours, it was a whole day. And this year now all employees and physicians have to go to culture training. But my point is they've realized how important the culture is, because you can throw money at people in healthcare, that really doesn't keep them. But it's really, how do you create a culture that is not only positive for employees, but also positive for patients? So this is one half of my team. This is the outpatient clinic team. We have another team that is remote, but they are a high performing team. And I'm going to show you, you're probably going to ask me, well, how do you know they're high performing? I'm going to show you some metrics around that, but they are a great group and they are happy. They are a pretty happy team. So I'm not going to talk about, we all know IR, we do tons of procedures. And what I'm going to show you is how we kind of built the clinical model out around interventional radiology and how we're now doing it for diagnostic. Because IR basically started out, as basically inpatient care, where there's just simple procedures that they were doing on, especially inpatients, drains, tubes, paras, vascular access, biopsies, thoras. And basically all they needed at that time was a physician, an IR physician, then you got the support of the RN and technologist on the inpatient side. But as IR began to evolve, we began to hire more APPs in that space to basically perform some low-hanging fruit procedures. And so we either had APPs in clinic or we had APPs in procedures. So it was basically, again, APPs and physicians. So as we begin to do more complex procedures that required longitudinal care and patients had to come back to clinic pre and post, we had to provide that clinical support. So we began to build out our teams and we did a lot of role development in this. So if you have an outpatient clinic, you need that support of RNs, medical assistants, schedulers. So currently, we have 40 plus clinical staff that are hybrid and remote that actually keeps interventional radiology running. But we did this through all of those 5 things that I showed you. We didn't just arbitrarily hire people. We actually planned out what was needed and where. So one of the things, we went under a period of significant growth, but all of our doctors have a clinical support team. Every doctor has an APP or a navigator and an MA that's assigned to them. And that clinical care team, basically they review every order and consult. They make sure patients are procedure ready. They do the pre-calls, rooming if we're in an outpatient clinic, all of the education, post-calls, discharge care, making sure patients are coming back for return visits, follow-up procedures. But basically this team kind of closes the loop. Our APPs, the growth, I said when I left, 5 years ago as chief APP, the APP team has now doubled again. So we have 40 MPs and PAs. Like I said, we have 10 hospitals, but 8 hospitals that are in Metro Atlanta. And our APPs do a variety of things. They are hybrid, which means they not only do procedures, but they do clinical support, consults. They also, some of them also do clinic. They are on 410 shifts, which is something that retains them. But what we wanted to do was create this redundancy among our APP teams, also our nursing teams and our schedulers, because we had a lot of single points of failure where you had one PA that was doing procedures, but if they went out on FMLA, it stopped. So we train our APPs to do multiple things. We train our nurses to do multiple things so that our MAs actually do their MA. We changed them to MACs, which means they can do administrative work like front desk check-in and the back office things, so that we always have staff and we're never going to have a gap. But as you can see, that's just showing you at each hospital location what APPs actually cover. So they're in CT. Our APPs run ultrasound 100%. They're in IR doing procedures. So like I said, a pretty big team. So now what we're in the middle of is developing the same type of model in diagnostic radiology around neuroradiology, nuclear medicine, breast imaging, abdominal, and fluoro, because these modalities are doing more and more procedures. So we're trying to bring that same model over to diagnostic radiology to make sure that those patients are getting the same clinical model in the same care as they are in interventional radiology. So that's requiring some role development, which we are undergoing, and it's also going to cause, we're going to have to shift, say some staff over to what we call physician division or ambulatory. So just trying to match people with the work that they're doing. And one of the things we focus on is making sure whether you are a technologist, a nurse, an APP, that everybody is working at their highest scope. That's really, really important. So we talk about system level initiatives, what they have done to help. We have our technologists got improved comp models. They now have a better career ladder. We've had major emphasis on patient access around the patient experience and employee sense of belonging. So this is our APP team. They are, I think, overall really happy group. They work very hard, but overall, again, you see smiling faces that they really are overall very happy. So finally, what is the evidence that we have these highly effective clinical care teams? These are just some of our technologists, our nurses, MAs in these pictures. Well, turnover. So this is our latest data for my particular team. This includes the APPs and our clinical nurses. Our overall turnover is 5%. That's pretty low, right? So this is evidence that we are doing something right. Our sense of belonging down at the bottom, we're in the middle of pulse survey now. So this last one was done, I can't remember, but we were at 78%, which we are aiming for, I think, 85. So this is Emory Healthcare system-wide. We have 30,000 employees and a turnover rate of 13.8%. So that's an indication that things are moving in the right direction. This is our sense this is our sense of belonging for our employees. This is by year. So the green is February 25, and this is August of last year. So again, as you can see, we dipped in August. And I'll tell you why we dipped in August, because we opened more outpatient clinics. So our MAs and RNs had to come in and do more in-person work. We are committed to hybrid, but it no longer could be 2 days. We had to extend it sometimes to 3 to 4 days, and they got mad. although we had talked about it. So it took several months to get them stable again, although we had talked about it for a year that y'all, we're opening more clinics. You're not going to be able to stay at home, 3 days a week. We got to come in and take care of patients. We had a large telehealth practice post-COVID. But now, y'all, we've got to see patients in person again. So we dipped, but now you see we kind of rebounded by really, listening. We had to do some friendly, terminations of some talk. Well, they terminated themselves. People terminate themselves. You just have to hold them accountable, and they terminate themselves. Our physician turnover, 6.3%. This is just in radiology, 6.3%, which is really low. Our likelihood to recommend for our outpatient clinics, for January, it was 84.35. Our total for fiscal year is 86.3. So because our employees are engaged, that's going to positively affect your LTR. In our APPs are productive in all of their roles. We meet our clinical FTE per provider RVUs. So all of our metrics are at target. So I end to say, I think there is a method to the madness, no matter where you work or what employees you have. I think we just have to kind of really take a look at the culture in your department, what's going well, what's not going well. Talk to your employees about where they are. I think if we were to just take a few minutes and kind of look at the culture and begin to really be intentional around it, well, you can begin to, I think, retain more. And also looking at, the generational shift is real, not just in our industry. It's real. That's what Jamie and I on the patient experience this morning. It's like we have to almost retrain that generation on customer service. I don't think they've gotten a lot of it, but I do look at like the Chick-fil-A's of the world, but it's because they've invested time in training them on customer service. And we've got to get back to doing that in healthcare as well. But I am done. Thank y'all for coming. Do y'all have any questions or thoughts, or y'all just ready to go in fiesta?